Welcome back to Uncovering Bailey and Love with Snazzy Surgeon. You know, in breast surgery, we encounter so many interesting cases, and sometimes it's the subtle differences that make all the difference. Today, let's dive deep into two common but distinct breast lesions, fibroadenomas and Phyllodes tumors.
Oh, absolutely. And you hit the nail on the head there. The subtle differences are key. It's about those nuances in presentation and management.
Yeah, for sure. Now, starting with fibroadenomas, I mean, these are the bread and butter, especially in our younger patients, right?
Yeah, definitely. You're talking about that 15 to 25 age group where fibroadenomas are the most common breast lumps we see.
And most of the time, they present pretty classically, right?
Yeah, typically you're feeling a well-defined mass, maybe around 2 to 3 centimeters.
And if the ultrasound looks good, then observation's often the way to go.
Exactly, especially in those younger patients. But there are definitely some red flags that would push us towards a biopsy.
Right, so age is a big one. I mean, if a woman's over 25 and presents with a new lump, we're probably getting a biopsy.
Absolutely. Age is definitely a factor.
Yeah.
And then, of course, any suspicious features on imaging.
Like microlobulations, those are always a concern.
Yeah, microlobulations or any other atypical findings on ultrasound would make me want to get a closer look. And, it's worth mentioning that in some cases, we might even consider medical management.
Oh, that's right. Anti-estrogen therapies like tamoxifen have shown some promise in shrinking fibroadenomas.
Yeah, it's not our first-line treatment, but it's an option to keep in mind, especially if surgery isn't ideal for the patient.
Now, let's talk about those giant fibroadenomas. I mean, those can be quite impressive, especially in teenagers.
Oh, those are the ones that can really grow quickly. We're talking about lesions exceeding 5 centimeters, sometimes even larger.
And during puberty, you can see some pretty rapid growth.
Exactly. Those are the ones that can be a bit alarming for patients, but thankfully they're usually benign.
And typically we can manage those with enucleation, right?
Yeah, a submammary incision and enucleation usually does the trick.
But it's important to remember that even though we consider fibroadenomas to be benign, there's still a slight increased risk of cancer down the line.
Oh, absolutely. We always have to have that conversation with patients. A simple fibroadenoma carries a relative risk of about 1.5 to 1.7.
But that risk goes up if there are certain findings on pathology, right?
Right, if we see epithelial hyperplasia, that bumps the risk up to 3.4 to 3.7. And if it's a complex fibroadenoma with a family history of breast cancer, particularly lobular carcinoma, then the risk climbs even higher to 3.0 to 4.0.
So those are all factors we take into consideration when deciding whether to excise a fibroadenoma.
Definitely. And, there are other factors too, like the patient's age, the size of the lesion, any suspicious features on imaging.
Right, so if a woman's over 30, or if the fibroadenoma is larger than 5 centimeters, or if there's a strong family history of breast cancer, those are all situations where we might recommend excision.
Exactly. And of course, we always take the patient's preferences into account.
And I guess when we're excising, especially in older patients, we want to take a good margin to make sure we're not missing anything.
Oh, absolutely. We always want to make sure we're getting clear margins, especially in older patients where there's a higher chance of finding something unexpected, like a malignancy or even a Phyllodes tumor.
Which brings us to our next topic.
Phyllodes tumors.
Yeah, these are a different beast altogether.
We used to call them cystosarcoma phyllodes, which sounds a bit intimidating.
It does, doesn't it? But that name has fallen out of favor, thankfully.
So Phyllodes tumors, we tend to see these in an older population compared to fibroadenomas, right?
Yes, usually women over 30. Although they can definitely occur in younger women as well.
And clinically, they often present as quite large masses.
They can be huge, sometimes even massive, with a bumpy, irregular surface. Because of the size and pressure, you might even see some skin ulceration. But even with their size, they're usually pretty mobile.
Yeah, at least initially, they tend to be freely movable on the chest wall. Later on, they can become fixed, but that's usually a sign of more advanced disease.
Now, histologically, Phyllodes tumors are kind of unique, right?
Yeah, they're true mixed tumors, meaning they have both epithelial and mesenchymal components.
Which is why they can sometimes mimic fibroadenomas on initial assessment.
Exactly. But the key difference lies in the mitotic activity, and that's how we classify them as benign, borderline, or malignant.
So how does that work exactly?
We look at the number of mitoses per 10 high-power fields. Less than 4 is considered benign, 4 to 9 is borderline, and 10 or more is malignant.
And those malignant phyllodes tumors, they have the potential to spread, right?
Yeah, they can metastasize hematogenously, which is why we need to be aggressive with our surgical management.
So wider excisions are the standard for phyllodes tumors.
Absolutely. We aim for a 2 centimeter margin, including the skin, and sometimes even the underlying pectoralis muscle, depending on the location and size.
And mastectomy is reserved for those really large or recurrent tumors?
Yeah, or for those that are clearly malignant.
And what about adjuvant therapies? Did those play a role in phyllodes tumor management?
Yeah, they can. Postoperative radiotherapy might be considered for recurrent tumors or high-grade malignant tumors, and systemic chemotherapy is an option if there's evidence of metastatic disease.
So to wrap things up, fibroadenomas and phyllodes tumors, while both presenting as breast masses, have distinct features that dictate our management.
Absolutely. Age, clinical presentation, histological features, they all play a role.
And it's crucial for us as surgeons to be aware of those nuances to provide the best care for our patients.
Couldn't agree more. It's all about individualized treatment based on a thorough understanding of these lesions.
Thank you for listening to our podcast. See you in the next episode.